Thanks for staying too late. Uh, we'll try to make it concise and interesting as we can. So I will share with you my experience for more than 15 years diagnosing and treating cases of BPPV. BPPV is the most common vestibular disorder. And in our experience, it constitutes almost half of the dizzy patient in our clinic. Mastering its diagnosis and management has built my reputation in the field. Repositioning maneuvers are the most successful intervention in the field of audiovestibular medicine, in my opinion. So diagnosis of BPPV, same history, examination, and investigation. For the history, typical history is very common. From the history, if the patient is telling you, I feel spinning when lying on my right side on the bed. I think there is no other diseases which can cause vertigo upon lying on the bed to a specific direction. Very, very remote and rare possibility of cases like vertebropatellar insufficiency, but in most of the cases, that's a very unique history. So postural hypotension, no. Dizziness occurs when the patient stand up or turn from the bed. But when lying on their back to the bed, feeling spinning, that's very, very characteristic and very specific to benign paroxysmal positional vertigo. So sometimes from the history, we know to a great extent that this patient has benign paroxysmal positional vertigo. Unsteadiness while walking can be the presentation of the horizontal canal BPPV. Most of the literature in the text box, especially the NT box, always describes the benign paroxysmal positional vertigo as the one from the posterior canal. But horizontal canal has a little bit more different presentation sometimes. The symptoms are more severe, and the vegetative symptoms, nausea, vomiting, more severe, and sometimes it causes dizziness, lying on the bed, rolling in the bed, turning on the bed, bending his head down while walking. Because in most of the daily movements, lateral canal plane got stimulated. So, and it causes dizziness and vertigo when the patient turns to the right and when the patient turns to the left. So the presentation of especially the horizontal canal, sometimes it can be presented by just unsteadiness. That some patient, I have seen this many times, they just complained of lightheadedness. And I tell you something, I learned it from failing to diagnose one case. I have attended one case, and we, in the first examination, I couldn't find any positional nystagmus. And we checked the blood pressure. He was elderly, hospitalized patient, and we checked the blood pressure supine. Then in the standing position, there was significant difference. I was happy that's a case of postural hypotension. Then the symptoms recur back, and one of my ENT colleagues asked me, please go and check again. And the patient has very robust and very severe benign paroxysmal positional vertigo. Then I keep on reading and trying to understand. I discovered something very interesting. You know, when we lie down, supine, there will be some circulatory changes. And when you stand up against the gravity, so there is some reactions to maintain the circulation against the effect of gravity. Some sort of reflexes occur, and the peripheral muscles got contracted to push the blood more to the brain. Ask yourself, what is the part of the body which feels that you are supine, then you are standing? Which organ in your body which feels the effect of gravity? You are with the gravity or you are against the gravity? It is the otolith organs. It is the otolith organs. This is the utricle and saccule, which tells the body, which tells the brain No, now we are standing. You have to execute some circulatory reflexes. You have to do some changes with the smooth muscles and the peripheral muscles, because now we are standing against the gravity, and the blood has to be pushed from the legs to the brain higher. So we found that, and recently there was some articles associating the postural hypotension to the vestibular disorders, especially the otolus dysfunctions. And as you know, in benign paroxysmal positional vertigo, it is an otolus disease. There is some degeneration of the otoconial layer in the utricle. So just keep this in mind, because in our experience, the association between postural hypotension and otolus dysfunction, we found this in many of the cases. More common on the sleeping side. So one of my very short history is just you lie on your right on left. Because in 95% of the cases, BPV occurs at the side where the patient used to lie. So if the patient lies on the right side, most probably you will find it in the right side. Left side, left side. So history, you ask for the age. It's more common with elderly people and more in females. Heat trauma. And we did unpublished study a few years back. We have seen many patients with mild to moderate head trauma complaining of vertigo, and surprisingly, most of the vertigo was due to benign paroxysmal positional vertigo. So especially in mild and moderate head trauma, most of those complaining of vertigo, you will find testing of BPV is positive. Ear symptoms and ear surgery, you are aware of this. Other otological diseases, Meniere, sudden sensory neural, hearing loss, labyrinthitis. Migraine, there is a strong correlation between the migraine and the BPV. BPV more common in migrainer, and sometimes the migraine causes positional, migrainous positional vertigo and nystagmus. So there is a strong relation. So I would want you to think pacemaker, eye surgery, breast surgery, dental procedure. I put this myself, especially the first two. I found it's very common with patient using have a surgery and they place the pacemaker, and some of patient who recently did eye surgery, and some patient who did a mastectomy because of a breast cancer. Any disease, and also on some patient with hemiplegia, any medical conditions which necessitates that the patient lie only in one side most of the time, in no time they develop benign paroxysmal positional vertigo. Because normal people, they turn right, left, but those with a pacemaker on the left side, really they feel pain if they lie on the left. So most of the time they lie completely every day, all the time on the right. So that's increased the risk of benign paroxysmal positional vertigo. Some eye surgery, our ophthalmology colleagues, they prohibit the patient from lying in certain side. I don't know the surgeries, but I have seen this many times with them, that after this restriction and being lying only in one side for a few weeks, that's definitely you can expect benign paroxysmal positional vertigo. Same for cancer breast. Sometimes they don't feel comfort lying on the operated side. And also for hemiplegia. With dental procedure, yes, and it's not uncommon, that is the dental position during the procedure provokes the attack, and the dentist got panic when the patient started to scream because of the vertigo and the dizziness. And drilling, any kind of skull drill, for any reason, dental, neurosurgery, craniotomy, otology, mastectomy. So drilling causes some sort of trauma, and it causes the otoconia to be dislodged from the utricle. Ototoxic medication, yeah, I have seen, and cranial radiotherapy for cancers or something. We, in our experience also, we found we expect every time we see a patient referred for ototoxicity monitoring because of gentamicin or aminoglycosides or cisplatin, we expect that we see bilateral vestibular loss. But up till now, most of the patients which we have seen, they have benign paroxysmal positional vertigo, because it's a subtle degeneration in the otoconial layer and utricle. So we don't have to have this rigid pattern in our mind. Just examine the patient scene. But now I do believe that any kind of ototoxicity, vestibulotoxic medications or cranial radiation, it also can cause some sort of degeneration of the otoconia. So let me to share with you this, this case. 19 years old young man referred to me after head trauma. He was diagnosed as translabyrinthine left temporal bone fracture. Seen few days after the trauma, we did the hearing test and vestibular assessment, and it revealed left total hearing and vestibular loss. Then, interestingly, we found the riot on the healthy side, non-affected side, the right posterior canal benign paroxysmal positional vertigo. And surprisingly to me, his main complaint was from the benign paroxysmal positional vertigo, and not from the total unilateral vestibular loss. He's a young man, and the natural compensatory mechanisms occur after the total unilateral vestibular loss. But no habituation occurred for the positional vertigo because it's episodic. The brain can be habituated if regularly exposed to the triggering factors. But it's not expected when it will occur the benign paroxysmal positional vertigo. But it was surprising to me that his main complaint was because of the right BPPV from posterior canal, and after repositioning, he feels very well. So, etiology of benign paroxysmal positional vertigo, I like to classify into primary, secondary, and post-traumatic. So, primary, there is some risk factors, including old age, osteoporosis, vitamin D deficiency, vertebrovascular insufficiency, migraine. Secondary to otological disease, Meniere's disease, labyrinthitis, vascular autoimmune, or ear disorders or surgery. Post-traumatic, and there is a very specific definition for the post-traumatic BPV, that head trauma, even the minor ones such as domestic injuries, sport injuries, school injuries, and dental care can trigger otoconial detachment, leading to the development of BPV, only labeled post-traumatic if it occurred 24 to 72 hours following the head trauma. So this is the post-traumatic benign paroxysmal positional vertigo. Classification is the best classification to classify it based on the affected canal. So posterior canal, the most common because it's the most dependent canal with the gravity, so it has a higher chance for precipitating the debris. Then lateral canal, which in our series is up to really 25% of the cases, and this is one of the most commonly misdiagnosed cases in other hospitals or clinics, because people typically, they look for the Dixwell bike, but very few of them, especially in family medicine practice, or this one just who wants to do the McClure-Bagnini test. Anterior semicircular canals also in our experience is up to 2%. Then multiple canals in our series is almost about 10%. So a diagnosis of BPV, history, provoking maneuver, characteristic nystagmus, then some special investigations. So everybody knows the Dixwell bike, and everybody also knows the side-lying maneuver, which we call it also the diagnostic Seamount maneuver, because sometimes some people don't tolerate the Dixwell bike because of cervical spine issues or before of biophysical limitations. So this is still a valid maneuver for testing. And if you are able man or a able person, so you do the Dixwell bike. But if you are a Seamount, you prefer Seamounts for repositioning. It's wise to do the side lying. Then if it's positive, just complete the Seamount. And if you are in preference for able maneuver, just to do the Dixwell bike. If it's positive, just complete the treatment. So provoking maneuvers, Dixwell bike for anterior and posterior canal, side lying also for anterior and posterior canal, head hanging for lateral canal, for anterior canal, and sometimes also used to diagnose special cases of posterior canal. Supine roll, which here I prefer the McClure-Bagnini maneuver name because supine roll is not in that brain. Supine roll is in the roll page, and one of the colleagues talk about this in the morning. So the right name to call it head yaw test, because you do like this. So this is a head yaw test. So I prefer McClure-Bagnini maneuver. Unfortunately, with the Cyclops system, they put this name for me. Then the Pauline maneuver, again, it's used to diagnose the horizontal canal BPPV or the what's called light copula or heavy copula syndrome. Then side lying test for horizontal canal, similar to the Simon side lying for posterior canal, but the head is straight. No 45-degree turning of the head. Just keep the head straight, bring the subject to the right 90 degree or to the left 90 degree. So you can have also side lying for the horizontal canal. Having different examination maneuvers is good because sometimes there is physical limitation on the patient. A diagnosis should be related to the evoked nystagmus and not to the maneuver which elicits it. So sometimes horizontal canal or anterior canal show in the dixal pike. So it's not just feeling vertigo or having nystagmus, but having a characteristic nystagmus which points to affected specific canal. So the diagnosis should be based on the characteristics of nystagmus, not on the evoking maneuver. Both excitator and inhibitory stimuli of each canal are linked to a typical nystagmus. As every vestibular stimulus triggered by each ambulatory deflection provokes contraction of a couple of extrinsic ocular muscles, generating typical eye movement and characteristic nystagmus. And in the morning, we have one presentation explaining this, so I will skip these slides. This is some model we use it to explain the relation between the different semicircular canals and the extraocular eye muscles. Just I will share with you some videos. Unfortunately, this video is quality is not good, but as you see, it's from a posterior canal BPV, from right dixal pike. It's upbeating torsional nystagmus. I think this is was recorded from Cyclops system, and I want you to observe something. What do you observe? There is a lot of eye makeup, right? Yeah, there is mascara and the eyelashes. With other systems, I used to have difficulty. But honestly, with the Cyclops system, as you see, I can get clear capturing of the pupil and the eyes without any effort or without interference. So that was the McClure-Bagnini test. We started by neutral position, supine, then turning the head to right lateral position. You can see there is a right beating torsional, right beating mainly geotropic nystagmus on the right head lateral position. Then after the nystagmus subside, or after 30 or 40 seconds, we complete the sequence. We bring the head back to the supine neutral position. Yeah. Then finally, we bring the head to the left lateral position. So I want you to tell this is a case of right or left horizontal canal BPV. So now we are in the neutral position. So we'll wait, turning the head to the left, and please observe. Just compare the strength of nystagmus between the head lateral position and the left lateral position. Yes. So this was a left lateral horizontal canal or right horizontal canal BPV? Left, sure. This is geotropic type of and left horizontal canal BPV. Good. So this is actually from a recent patient. Interestingly, she is a young lady, 30 plus or something, and her habit of sleeping to lie on her face. And she started to complain of dizziness for 2-3 weeks. And on examination, we, on the right dixal pike, we recorded this. Just concentrate because she keep on blinking, so it's a little bit challenging to appreciate the nystagmus. In the Cyclops system, also recorded with the Cyclops system. So with the Cyclops system, you start by turning the head to the right 45 degrees on the sitting. Then after 30 seconds something, you bring the patient on the supine. So on bringing the patient to supine, just try to concentrate and see if there is any kind of nystagmus. You see any nystagmus? There is down beating with torsional element towards the left. Because she's blinking is a little bit hard, but if you focus, you will see a few beats. Can you see now? Yes. So this is, interestingly, in posterior canal BPV and in anterior canal BPV, the torsion directs you to the affected side. So because of the torsional component here was towards the left, our diagnosis was left anterior canal BPV. And interestingly, for anterior canal BPV, the presentation will be more robust in the right doxal pike. So the right doxal pike will show very well the right posterior canal BPV and the left anterior canal BPV. And we did for hair repositioning. And next week, we checked the hair. There was convergence to the horizontal canal. And we could treat it. And now she is cleared. But interestingly, her habit, she sleep on her face. So maybe this was a reason. Then next point is bilaterally symptomatizing PPV. So horizontal canal symptomize on the right and left. Anterior canal also gives symptoms on the right and left. And it gives a positive dixal pike with vertigo and nystagmus on both sides. But the nystagmus, the torsional component, it will be down beating with the torsional component beating towards the affected ear. Like our previous case, it was a left anterior canal BPV because torsional component was beating towards the left. Then pseudo-bilateral posterior canal BPV, then true bilateral BPV. In our clinic, we have a rapid access clinic, so we see many patients from emergency department. And we are a tertiary care hospital, so we have a lot of head trauma cases. So what makes multiple canal and bilateral canal little bit higher in our series, that we see a lot of post-traumatic, post-head trauma cases. So this is our protocol to differentiate between pseudo-bilateral and true bilateral. So if you have bilaterally positive dixal pike test, either it will be one side is more symptomatizing or both sides are equal symptoms and nystagmus. So if you have one side more symptomatizing, just treat the most symptomatizing side. Then if the nystagmus and symptoms are cleared after treatment, that is the case of pseudo-bilateral BPV. But if after treating the symptomizing side, the other side is still symptomatic and still shows nystagmus, that must be a true bilateral posterior canal BPV, and you have to treat the other side. Then, if you have equal symptom and nystagmus, just do head hanging maneuver, just a head extension in the neutral plane. So, if you got a torsional nystagmus, that means it will be beating towards the affected ear. And that means the case of pseudo-bilateral BPV, treat the side where the torsional nystagmus beats towards it. If you have a purely vertical nystagmus, and why purely vertical nystagmus? Imagine that is the right ear has upbeating anti-clockwise nystagmus, and the left ear has upbeating clockwise nystagmus. So the clockwise and the anti-clockwise components will cancel each other. So the torsional components will cancel each other, and only you have a purely vertical nystagmus. In this case, it will be a true bilateral benign paroxysmal positional vertigo, and you do Simont maneuver for both sides simultaneously, or just do Ibli maneuver on consequent sides. So because in Ibli maneuver, if you treated one side, when you wanted to treat the other side, really it will affect the treated side. But in cement maneuver, there is no such interference. So either you choose, you do cement for both ears at the same session, or just do Ibli for one side. Then after a few days, you do the Ibli maneuver for the two sides. And in our experience, both protocols, they work very well. So multiple canal BPV, most common is a mixed combination between horizontal and posterior canal BPV. It's the most common form of mixed canal BPV. Involved canals may be on the same or on the opposite sides. Diagnosis based on the features of nystagmus on either maneuvers, dixohalbaic or supine roll. In most mixed cases, the horizontal nystagmus is geotropic or apogeotropic. I will show you some videos, but for the horizontal canal, you have nystagmus on the right, which got reversed when the head to the left. So there is a tool to get sure of the involvement of the horizontal canal. That is, the nystagmus is bipositional and reversible, either geotropic or apogeotropic. So if you have a right beating nystagmus on the right side, when you test the left side, it will give a left beating nystagmus. But horizontal, but posterior canal only on the affected side. So there is a way to double check if horizontal canal involved or no. So you do the dixohalbaic, then you do the supine Yao test or McClure-Baghdini test. If you have the typical bidirectional, bipositional nystagmus of horizontal canal, that makes you sure of the involvement of the horizontal canal. So please watch this video and give me your comments. Can you see? Yeah, very strong upbeating torsional component. Then what happened? Yes. So the upbeating torsional component followed was transient, then followed by a more prolonged horizontal component to the right side. So this is, and when we do the McClure-Baghdini test, there was a reversible horizontal component on the other side. So we get sure this is a case of mixed posterior and horizontal canal. Good. So in the next, we have another one. Good. So let's, this is recorded by the Cyclops system, and give me your comments, because I think this is one of the interesting videos you might watch. So this was the right dixohalbaic test. So first is the head turned to the right 45 degrees. Then after some time, we bring the head into the supine position. Okay. Yes. Please concentrate. There is some tricks here. Yes. Yes. Just watch, please, because this is really one of the interesting videos. Yeah. Still the story didn't end. Yes. So what happened? We have very strong upbeating torsional nystagmus. Then it was followed by a down-beating nystagmus. This is one of the colleagues presented a similar case, and he labeled it as central, simply because of this strong nystagmus. It has a rebound nystagmus on the opposite side. If the copula become robustly tilted or moved, so there will be some rebound. So this was the rebound. It wasn't anterior canal, but it was rebound for the strong nystagmus from the posterior canal because of the markedly deflected copula of the right posterior semicircular canal. So if strong deflection, it will be inhibited by some sort of rebound. So you get this, this rebound nystagmus, followed by lift beating horizontal nystagmus. This was a case of severe posterior canal BPPV in association with apogeotropic horizontal canal, and we cleared the patient in 1 or 2 sessions completely. So we are sure from the diagnosis. But again, your trick, that is always for the horizontal canal, you can double check the reversal of the nystagmus on the McClure-Bagnini test. And for your knowledge, any strong nystagmus always has a rebound opposite direction nystagmus, even in caloric test. So if you observe you're still doing the caloric test, if you have very strong hyperexcitable caloric response, wait little few minutes, you will have spontaneously a reversed direction nystagmus. It's called the rebound nystagmus. So if you have a mixed posterior and lateral canal BPV, which canal you treat first? There is 2 schools. One school telling treat the posterior canal first, as it is the reservoir for otoconia, because it's the most dependent and most of the otoconia precipitate in it. As the other school telling if treat the lateral canal or horizontal canal first, because it's usually more symptomatic. And I do believe both of them, they work. Mixed posterior and lateral canal, which canal is the same? Mixed anterior and lateral canal BPV. If you have anterior and lateral canal BPV, which canal would you treat first? I have a case of mixed anterior and lateral canal BPV. So which canal you treat first? Yes, correct. Why?
Because it is associated with so much neurovegetative symptoms, it is very troublesome for the patient. And anterior canal by itself can also.
Correct. And the other reason that simply anterior canal has a chance of self-clearance. And it happened many times. So I would treat also the horizontal canal first. Okay. Yeah, still 2 more or... Yes. This is one of the places where I work. I work in many clinics. So they don't have a VNG system. They just have all the video nystagmography camera. And I captured with my mobile. Listen, that's because I put here because if you can see there is vertical upbeating nystagmus. So it's very common that is people get confused. If you have spontaneous vertical upbeating nystagmus, that means central. And you have to do imaging or to refer to a neurologist. But many normal people or those with smokers or those with migraine, sometimes they have vertical upbeating nystagmus 7 degrees or less at positional testing. So it's different. If you see spontaneous upbeating nystagmus, that means mostly a brainstem or high brainstem problem. But if you find vertical upbeating nystagmus on positional testing in Dixwell bike or head hanging or supine, that's sometimes a normal finding, more common with those smokers. And in our experience also, it's more common in migrainer. So this is with vision denied, means in dark. So we don't take it very significant. But if you find spontaneous vertical upbeating nystagmus, this is a very strong red flag, and it should be investigated. And I think that case was a spontaneous vertical upbeating nystagmus. It seems out to be multiple sclerosis, as I remember. There is a new, yes, I have been asked by respected colleagues that is about, he was testing one patient for horizontal canal, and she was, it was geotropic, then spontaneously it became apogeotropic. Simply, The concept of copulolithiasis, in my opinion, now is little bit changing. Because copulolithiasis concept, that is the otoconia is adherent to the copula. But which makes more sense is that is the matter of the short arm and the long arm. So if the otoconia is here, it causes apogeotropic nystagmus. If the otoconia here, it will causes geotropic nystagmus. And this is easily explains the conversion. I believed in this theory simply because I have seen the spontaneous conversion. If it's in the short arm, if it's moved the otoconia and become in the long arm or non-ambulatory ambulatory arm, so spontaneous conversion can happen. This is explains your question because it shouldn't be copulolithiasis doesn't mean adherent to the copula, but it just could be it is in the short arm of the canal. Because if the otoconia is here, it will give you a copulolithiasis finding. If the otoconia is here, it will give you a geotropic. So just moving the otoconia from the short arm of the canal to the long arm can simply cause a spontaneous conversion of the nystagmus. There is a new variant. There is few papers on it. It's called apogeotropic variant of the posterior canal. Personally, I have 2 or 3 cases presented with just a very strong torsional nystagmus on the Dixie-Holbein test, but with a reversed direction of torsion. So you expect it to be like the torsional component towards the affected ear of posterior canal, but I found it in the opposite direction. So the theory goes that it's either the otoconia will be here or in the common cross. So that's why sometimes you got presentation similar to the anterior canal or the direction of torsion. Everything is typical except the direction of torsion is reversed. But still, only a few articles published on this concept. How to determine the affected side of the horizontal canal? Yes, intensity of nystagmus. In geotropic, it's more stronger in the affected side. In apogeotropic variant, it's weaker on the affected side. Pseudo-spontaneous nystagmus. In geotropic variant, it will be beating towards the healthy side. And in the apogeotropic type, it will be beating towards the affected side. Also, setting to supine test, the nystagmus will be the same like pseudo-spontaneous nystagmus. Head bending nystagmus, affected side on geotropic, and beating the nystagmus will be beating to the healthy side in apogeotropic. Null point more common in the apogeotropic. Just here we have to give a hint that sometimes this apogeotropic variant or even the geotropic, sometimes I heard from the colleagues that they have cases which never respond to the treatment. Those cases, we call them, we label them as light copula and heavy copula. So in light copula, it gives you this geotropic nystagmus, and in heavy copula syndrome, it gives you apogeotropic type. It's similar to the alternating alcohol nystagmus, because you know alcohol goes first, get absorbed in the copula. So at the beginning, it causes light copula syndrome, so it causes geotropic nystagmus. After a few hours after clearance from the copula and going to the endolymph, it become more, the copula will become relatively heavier than the endolymph. So the direction of nystagmus will get reversed. Light copula can happen with migraine, and most of the cases in our experience and also in the literature, it always gives either geotropic or apogeotropic. So if you have a case of horizontal canal BPV, which is not responding to maneuvers, and you did the MRI and it was free, think about the light copula syndrome. And the most common cause of light copula syndrome is migraine. So give the treatment for migraine. Just a few tips, just 2 slides left. I give you a few tips for treating successful treatment of BPV. When you are doing Eble maneuver, this maneuver works mainly with the gravity. So giving more time, especially in the, when you bring the head down, just I give it 2 minutes. I give time for the gravity to work and for the debris to move. If you make it very fast, 30 seconds, sometimes this is a cause of not being successful. Same also in the when you turn the body to the other side. I keep it for 2 minutes again to give more time for the otoconia to go to the common cross. So just the timing, because this maneuver depends on the gravity. So please give the gravity time to occur. One more tip for the Ibli, always keep the head in position. When at the final step bringing the patient to the sitting, keep the head turned, because that's prevent immigration or conversion to the horizontal canal. For cement maneuver, the secret for its success just to bring the head more down. So instead of 180 degrees, just make it 210. Just in the initial position, make the head more down. Then also in the second position, make the head also more down. So just make the curve more, not only 180, but 210 or 200 plus. That improves. The other thing in our protocol, we repeat the maneuver, but at least 10 minutes apart. Because if you repeat immediately, you just disturb what you fixed before. So at least we wait for 10 minutes, but we believe, as also the literature suggests, that the repeating the maneuver one more time, especially sometimes if the patient first time to receive the treatment, they don't know what will happen. They are not very cooperative, they are panicking, they are afraid. So sometimes I find the second time more convenient for the physician and also more comfortable to the patient. So that's what we do. So usually we start with Ibli, then if it failed, we do cement maneuver, and if failed, we use a vibrator. I use a massage vibrator, but I have to share with you, there is a contraindication for the use of vibrator. If your patient has a retinal detachment, please don't use the vibrator. It can worsen his condition. So the use of skull vibrator is contraindicated if the patient has a retinal detachment. Maneuvers of horizontal canal, we use number one, the forced prolonged positioning maneuver. This is our favorite, and we always got a very good result with it. So just wait for the patient to lie on the healthy side or the healthy side for many hours as he can, at least 10 to 12 hours for 2 successive nights. And sometimes we combine it with euphony maneuver. We find it more easy to do for the patient. And sometimes we do the barbecue or the log roll, but both euphony and barbecue, it doesn't work from one treatment. Sometimes you have to repeat many times to work. So we combine many times of euphony or barbecue, and as well as the forced prolonged positioning maneuver. Forced prolonged positioning maneuver is the standard in all the patients with horizontal canal. Interestingly, especially for apogeotropic type, if the otoconia in the utricular side, sometimes if they lie on the hill side, it doesn't clear. So you have to let them to lie for 1 night or 2 nights on the affected side, then after that, return back. So don't be very stubborn. If the patient didn't clear by lying on the side you suggested for 2 nights, just reverse his position. Sometimes it works very well. So there is many, the mechanism, like in barbecue, limbrette, and Asprilla maneuver, they use the angular acceleration and the negative inertia. Euphony maneuver, it uses linear acceleration and positive inertia. And forced prolonged positioning maneuver uses gravitational sedimentation. For anterior canal, we may do a deep head hanging maneuver. And I do believe if you turn the head towards the affected side, like in Dixwell bike, sometimes it gives better results. It's all the same, deep head hanging, deep head Dixwell bike or lean. Reversed cement or reversed Ibli maneuver sometimes work for them. But our standard of care is the deep head hanging maneuver. Thank you very much.